Hello everyone, my name is Gwen Driscoll. I'm the Director of Communications here at the UCLA Center for Health Policy Research. It's my pleasure to welcome you once again to our 2016 Health Policy Seminar Series. We're very excited about today's topic. If you saw the LA Times this morning, you will have seen it was in the A1 position on the front page of the paper. It's a big story about prediabetes in California, and we've got a really stellar speaker here to talk about it. But first, I just want to make a brief announcement about our next month's seminar. Please save the date of Thursday, April 14th for a seminar about a center-led grassroots campaign to reduce both smoking and exposure to secondhand smoke in apartment buildings in some of the most densely populated and disadvantaged neighborhoods in Los Angeles. This Smoke-Free Apartments Los Angeles initiative is part of a national CDC program to encourage voluntary smoke-free policies in private multi-unit rental apartment buildings in the city of Los Angeles and elsewhere. On April 6th, the center will present findings from a first ever survey of tenants and landlords in the affected areas, as well as launch an exciting new media and advertising campaign to encourage the adoption of smoke-free policies citywide. And on April 14th, here at the center, please join us for a seminar where the study's authors and advocates will discuss the project's findings, as well as how we can achieve a healthier and more equitable Los Angeles. Again, that is Thursday, April 14th at noon. As for today's seminar, we will be recording it, and it will be placed on our website at the address you see at the top of the slide. If you would like copies of today's presentation slides emailed to you, please send me an email at gdriscoll@ucla.edu. Please, if you want to know more about our upcoming seminars, events, new data, new research, we always have exciting things coming out. Please do subscribe to our once-a-month e-newsletter, Health Policy News. It is free, and you can subscribe at that link you see at the bottom. And also note we will have a brief question and answer period at the end of today's seminar that I will moderate. I am now happy to introduce today's presenter, Dr. Susan Babey. Sue is the co-director of the center's chronic disease program and a renowned expert on diabetes and the factors related to diabetes, including diet, physical activity, and the built environment. Sue is the author of numerous high-profile studies, including several examinations of the link between sugar, sweetened beverages, and obesity. She has looked at the devastating personal and financial impact of diabetes, which is tied to a third of all California hospital stays. She has also calculated a retail food environment index to measure the number of fast food and other unhealthy food outlets in a neighborhood and examine how this can be a driver of diabetes, obesity, and other serious chronic conditions. Sue is the author of a study released today that finds that nearly half of all California adults, including 1 out of every 3 young adults, have either a precursor to type 2 diabetes or undiagnosed diabetes. In total, a majority of the state's population is affected by this terrible but also preventable condition. Here to tell us what's going on and what policymakers can do about it is Dr. Susan Babey.
Okay. Good afternoon, everyone, and thank you for being here, either in person or virtually on the webinar. As Gwen said, I'm going to be talking about our new study we released today about prediabetes in California. Oops. Okay. Before I begin, I'd like to acknowledge a few people who really were integral to this work. My co-authors, Allison Diamant, Joelle Wallstein, and Harold Goldstein. I'd also like to thank Pan Wang, Akbar Esfahani, Carl Gans, and Hongjian Yu for their excellent statistical and modeling work. Our partner in this work was the California Center for Public Health Advocacy, and this study was funded by the California Healthcare Foundation and the California Endowment. So diabetes, particularly type 2 diabetes, is a significant health problem in the United States. In 2014, the CDC estimated that 29.1 million people in the U.S. had diabetes, or 9.3% of the population. Over the past 30 years, the prevalence of diabetes in the U.S. has nearly tripled. The next few slides are going to illustrate changes in diabetes prevalence by state between 1994 and 2013. Darker colors represent higher diabetes rates, and you can see how the country is gradually growing redder, indicating higher rates of diabetes. In 1994, almost every state had rates below 6%. By 2013, there were no states below 6%, and most states have rates over 9%. So these increasing rates of diabetes are problematic because diabetes can lead to a number of serious complications, including blindness, kidney disease, heart disease, stroke, and loss of toes, feet, or legs. Not only does diabetes increase the risk of serious medical complications, it's also extremely costly to families, businesses, healthcare plans, states, and the nation. In 2012, diabetes was estimated to cost $176 billion in direct medical costs and an additional $69 billion in indirect costs or lost productivity, for a total of $245 billion nationally. Prediabetes, which is also referred to as impaired glucose tolerance or impaired fasting glucose, is a condition in which blood glucose levels are higher than normal, but not high enough to meet the criteria for a diabetes diagnosis. People with prediabetes have a much higher risk of developing type 2 diabetes, as well as an increased risk of heart disease and stroke. In the U.S., 86 million adults have prediabetes. 90% of those with prediabetes are not aware that they have the condition. Over the past 10 years, the prevalence of prediabetes increased by nearly 25% among adults, and even more alarmingly, research published in 2012 indicated that rates among adolescents rose dramatically from 9% in 1999 to 23% in 2008. Without intervention efforts, up to 30% of people with prediabetes will develop type 2 diabetes within 5 years, and up to 70% of those with prediabetes will develop type 2 diabetes within their lifetime. However, there are effective interventions to prevent or delay the progression from prediabetes to type 2 diabetes. Results from the Diabetes Prevention Program clinical trial indicated that among those with prediabetes, weight loss from increased physical activity along with improvement in diet can prevent or delay the onset of diabetes significantly, particularly more significantly than medication or doing nothing. In fact, the results suggest that weight loss and increased physical activity can cut the risk of developing type 2 diabetes in half. So, lifestyle modification programs like those recognized by the CDC's National Diabetes Prevention Program can help people prevent the progression from prediabetes to type 2 diabetes. Now, I should mention that the results of this clinical trial also indicated that medication was more effective than doing nothing, but not as effective as the lifestyle modifications. And I believe there is work ongoing currently to look at whether the combination of the two, lifestyle modification and medication, would be more effective than either one alone, but the results are forthcoming on that. So, turning now to California, as of 2014, 9% of California adults report being diagnosed with diabetes, and this represents 2.5 million adults in the state. Just like diabetes is costly nationally, in California it's also very costly. The total cost of diabetes for California was estimated to be more than $27 billion, and this includes $19 billion in direct medical costs and $8 billion in indirect costs from lost productivity. In addition, the prevalence of diabetes in California has been gradually increasing since 2001. So this chart shows the trends in diabetes prevalence among California adults from 2001 to 2014. And the prevalence has increased from a little over 6% in 2001 to about 9% in 2014. And so this mirrors what we saw earlier in the U.S. prevalence maps, with most states moving from rates under 6% in 1994 to rates of 9% and above by 2013. All right, so now I'm going to talk a little bit about how we did this study. I'll start with an overview of our methods and then go into a little bit more detail. So we used two data sources for this study. First, data from the 2009 through 2012 National Health and Nutrition Examination Survey were used to build and test predictive models of blood glucose levels above cutoffs associated with prediabetes. This predictive model, developed in NHANES, was then applied to California data from the California Health Interview Survey, 2013 through 2014, to produce California-specific estimates of the prevalence of prediabetes. Similar approaches have been used by other researchers to estimate the prevalence of undiagnosed diabetes by state, as well as the prevalence of hypertension at the county level. All right, so a little more information about our data sources for this study. The National Health and Nutrition Examination Survey, or NHANES, is a national data set that is representative of the non-institutionalized population. It's conducted by the National Center for Health Statistics at the Centers for Disease Control and Prevention. NHANES participants complete a household interview as well as a physical examination that includes providing a blood sample. We develop predictive models from NHANES using data from the fasting subsample, and these participants have measures of both fasting plasma glucose as well as hemoglobin A1C, which are two blood tests commonly used to diagnose diabetes and prediabetes. Okay. And then a little background about CHIS, then I'll talk more about the specific method, the specific modeling approach that we used. So CHIS is a cross-sectional telephone survey that's been conducted in California since 2001. We use data from 2013 and 2014. Across those years, CHIS conducted interviews with over 40,000 households in California, which included 42,040 adults. Interviews were conducted in every county in the state in 6 languages: English, Spanish, Chinese, both Mandarin and Cantonese, Korean, Vietnamese, and Tagalog. The weighted survey data are representative of the California population living in households. The survey includes questions on health status, health behaviors, access to health care, demographics, and social characteristics. So our first step was to develop our predictive model in the NHANES data. To match the definition of prediabetes used by the CDC, we used both hemoglobin A1C and fasting plasma glucose to define prediabetes. And specifically, the cutoffs we used were hemoglobin A1C above, or 5.7% or above, and fasting plasma glucose of 100 or above. Adults who reported having been diagnosed with diabetes were classified as having diabetes and so are not included in the prediabetes estimates. Because we define our outcome based on cutoffs above certain blood glucose levels, our outcome includes both adults with prediabetes as well as those with undiagnosed diabetes. We did this to maximize our predictive accuracy because of the high degree of overlap between predictors of blood glucose levels above prediabetes cutoffs and those above diabetes cutoffs. However, those with undiagnosed diabetes represent a relatively small proportion of those with blood glucose levels above the prediabetes levels. Based on our analysis of the 2009 through 2012 NHANES data, about 3.9% of U.S. adults have undiagnosed diabetes. Another point that I wanted to just make sure folks are aware of is that because of changes in measurement methods across surveys, the National Center for Health Statistics applies regression equations to fasting glucose values collected in NHANES after 2005. This provides consistency with earlier estimates, but the current analysis does not involve comparison with earlier estimates. Therefore, fasting glucose values in this research are based on the current laboratory measurement methods and have not been adjusted to be comparable to values collected in previous NHANES cycles. Okay, so we started by identifying predictors in both NHANES and CHIS that were comparable across the two data sets. We used data from 6,422 participants in NHANES to develop our predictive model. The model was developed using generalized boosted regression models, or GBM, which is an R implementation of Friedman's boosting machine. A couple references up there if folks are interested in more details about this methodology. GBM uses an iterative machine learning algorithm that increases in complexity until it minimizes out of training sample predictive error. And we assess this using tenfold cross-validation. And this type of model was used rather than regular OLS regression or logistic regression because our goal was accurate prediction rather than testing the statistical significance of individual model predictors. So, our predictive model that was developed in NHANES displayed good predictive ability with both pseudo R-squared and a coefficient of determination of about 0.3. These metrics are taken from the cross-validation and so represent the prediction for cases not used in training. To get the California estimates that I'm going to be talking about shortly, we applied the GBM model to California Health Interview Survey data. We estimated variance for these rates using multiple imputation, and the multiple imputation or the variance accounts for both CHIS sampling and uncertainty in predictive modeling. Now, my slides aren't going to show the confidence intervals, but they are available on the study website for this policy brief. So, now I will turn to what we found. In California, 9% of the state's adult population report that they've been diagnosed with diabetes. This represents about 2.5 million adults in the state. In addition, we estimate 46% of California adults have prediabetes or undiagnosed diabetes, and this represents more than 13 million California adults. So overall, 55% or more than half of adults have either prediabetes or diabetes. The prevalence of both diabetes and prediabetes increases with age. About 2% of adults ages 18 to 39 have diabetes. This increases to 9% among adults ages 40 to 55, to 16% among those ages 55 to 69, and up to 20% among those 70 and older. Similarly, the rates of prediabetes also rise with age, from 33% among adults ages 18 to 39 to 49% among those ages 40 to 59. After that, prevalence levels off at around 60% among adults 55 and older. So I wanted to emphasize one of the findings that we found especially surprising, and that was the rate among the young adults. 33%, or 1/3 of adults ages 18 to 39, were estimated to have prediabetes. Now, high rates of prediabetes among young adults are especially concerning because the risk of complications from diabetes that I talked about earlier, kidney failure, stroke, loss of limbs, increases significantly the longer one has the condition. So the next couple of slides are going to focus on rates among young adults. Prediabetes disproportionately affects certain racial and ethnic groups, and the disparities are pretty noticeable among the young adult population in the state. So among those ages 18 to 39, more than 1/3 of Latinos, Pacific Islanders, American Indians, African Americans, and those of multiple races are estimated to have prediabetes, and these rates were significantly higher than the rate among whites, which was 29%. Statewide, among racial and ethnic groups, rates ranged from 42% among Asians to 55% among Pacific Islanders, with at least half of Pacific Islanders, American Indians, and African Americans estimated to have prediabetes. Now, rates also varied from county to county among young adults, but also among all adults in California. I included this slide to illustrate the variation, but the numbers are available in the policy brief that we released today if you're interested in the specific rates for individual counties. Just briefly, among adults ages 18 to 39, the prevalence of prediabetes ranged from 26% in Lake County to 40% in Kings County and Imperial County. Among this younger age group, only 5 counties had rates below 30%, and those were Lake, San Benito, Butte, San Francisco, and San Luis Obispo counties. So, to summarize the findings, more than 13 million California adults, or nearly half of the state's adult population, are estimated to have prediabetes, including some small proportion who have undiagnosed diabetes. This includes 1/3 of young adults who have prediabetes. There are also disparities in prediabetes prevalence, with higher rates among Latinos, Pacific Islanders, American Indians, African Americans, and multiracial adults. So, given these numbers, what should we do? These numbers are pretty alarming, but as I mentioned earlier, the progression from prediabetes to type 2 diabetes can be prevented, and we know that there are effective programs to help with this. So, these findings, we think, highlight the importance of prevention efforts in the state. Health promotion and disease prevention efforts, such as maintaining a healthy weight, being more physically active, consuming healthy foods and beverages, limiting the intake of sugar and other simple carbohydrates, can all help reduce the risk of developing type 2 diabetes. But to aid in the prevention of diabetes, we think that efforts from policymakers would be helpful, including support for diabetes prevention efforts. So, I mentioned earlier that most people with prediabetes don't know they have the condition. So providing insurance coverage for and ensuring regular medical practice of appropriate screening for people at increased risk can identify people with prediabetes while it's still possible to prevent the onset of type 2 diabetes. In addition, insurance coverage for and referral to recognized diabetes prevention programs can remove critical barriers to education and care for people with prediabetes, and can also facilitate the lifestyle changes needed to prevent to prevent type 2 diabetes. And all of these things require access to quality primary and specialty care with sufficient insurance benefits packages. Efforts to promote built environments that encourage regular physical activity and healthy diet can also aid in prevention efforts. Lack of physical activity is a risk factor for diabetes, and further policies to facilitate active living could be beneficial, including, for example, creating safe environments for walking and biking, providing access to safe parks and other places for recreation and physical activity. And this could include shared use programs that allow communities to use school grounds outside of school hours. And there's been a lot of work around this type of, or this method for increasing access to places to recreate. Offering worksite wellness programs that facilitate regular physical activity for adults of all ages can also be helpful. And UCLA actually has a great example of this type of worksite wellness program. They offer education along with free fitness classes to staff and faculty at different locations throughout the day. In addition, improving environmental supports for healthy eating can help people have healthier diets. So local and state policy initiatives that could help improve the food and beverage environment include increasing access to fruits and vegetables, decreasing marketing of unhealthy food options, encouraging large institutions, for example hospitals, to follow healthy food procurement guidelines. One of the folks that we talked to when we were working on this study was Fran Kaufman, and she kept saying to us, it's shameful that hospitals have all these poor food choices in their cafeterias and their vending machines. They really should be a model of health for other large institutions to follow. So she was really the impetus for including that recommendation. And then finally, ensuring the availability of safe and low-cost drinking water, with an emphasis especially on safe in light of the problems with drinking water in Flint, Michigan, and elsewhere. Okay, so thank you. I think we have time for questions.
So I'm going to lead with one from online. An initial question came about whether there was an interaction between prediabetes and BMI. I came across that.
Sure. So the question was whether there's an interaction between prediabetes or diabetes and BMI. Obesity is definitely a risk factor for both prediabetes and diabetes, and weight loss is one of the lifestyle modifications that can help prevent the progression from prediabetes to type 2 diabetes.
Okay. Someone in the room?
Yeah.
Thank you so much. My name is Annalyn Kaufman. I'm a postdoc at the School of Public Health. My question is whether you looked at gender in addition to the different age groups and in addition to the different ethnicities. There's some good evidence that shows that physical activity substantially declines in preteen and teen girls, at least in the UK, and that would set gender-based trajectories to be quite different. Physical activity is quite important for prevention. We need to understand the differences between women and men as far as that risk factor and actually prediabetes as a condition. So I was wondering if you did look at that and just couldn't include it in the group because of space, and if not, I would strongly encourage that.
Yeah. Okay, so the question was whether we looked at gender differences, particularly in light of declining rates of physical activity among adolescent girls relative to adolescent boys, which you see in the UK. We also see that here in the US. And I have to admit that I, in fact, have not looked at whether these prediabetes rates vary by gender, but that's a great suggestion, and we can certainly do that.
I'm just going to go online and then in the room, back and forth.
So are there estimates at the sub-county level? That's a quick one, so maybe.
So currently we have estimates at the county level, and for Los Angeles County and San Diego County, we have some sub-county level estimates.
And are those available?
Those are available on the publication page as supplemental tables.
Okay. Go ahead, sir.
Dr. Neil Kaufman, Canary Health from the Public Health School here. Sorry I missed most of the presentation. Were you able to really talk about the clinical and business reasons for prevention of diabetes programs beyond the prevention of diabetes? By that I mean, we've been able to show that you can lower the rate of adding new chronic conditions, sleep apnea, hypertension, high cholesterol, low back pain, depression, etc. That's really not having to do with prediabetes, diabetes. And my fear is that we don't have enough power in a short enough time frame to show a business and a clinical outcome just by preventing diabetes unless we demonstrate these other impacts.
Okay, so let me see if I can rephrase the question. The question was, were we able to look at other business impacts of prevention of these kinds of
other comorbidities.
Other comorbidities.
Prediabetes to diabetes.
Other than just the progression from prediabetes to diabetes. So the short answer is no, we didn't really get into that. But I think you raise a very good point in terms of strengthening the argument for this kind of preventive work more generally.
Okay. So, sort of related, how strong is the evidence that prediabetes develops into diabetes?
Okay, so the question is, how strong is the evidence that prediabetes develops into diabetes? And I should specify this is type 2 diabetes. Evidence from the Diabetes Prevention Program clinical trial suggests that between 15 and 30% of those with prediabetes will develop type 2 diabetes within 5 years without intervention efforts. And in addition, furthermore, I should say, up to 70% of those with prediabetes will develop type 2 diabetes in their lifetime without some sort of intervention effort. So I think there's strong evidence that there is this progression from prediabetes to type 2 diabetes. But there's also very good evidence that the progression can be stopped or at least delayed with intervention efforts.
Any questions from the room? We got a lot online. Go ahead, Dave.
I was struck, I think in the opening you said 23% of adolescents were diagnosed with prediabetes using the NHANES data.
Mm-hmm.
And I wondered if you could apply the model to the adolescent sample in CHIS to get an estimate of prediabetes, because, I mean, the earlier you intervene with the relationship between
Mm-hmm.
age and diabetes, the better. So.
Yeah, so the question was, earlier I mentioned research that used NHANES and found that 23% of adolescents have prediabetes. And Dave asked if we could apply our model to the CHIS adolescent data to come up with estimates of prediabetes among adolescents in California. And I think that would be something that we would love to do. And I think it would be possible if we have sufficient sample size.
What promise do you see from digital connected health solutions targeting prediabetes?
So sorry?
Question is, what promise or what's the outlook for digital connected online prediabetes screening management type programs?
Okay, so the question is, what's the promise from online or digital diabetes prevention and management? Okay, so I don't know specifically if there's research that has compared online programs versus sort of more, I don't know, in-person management programs. But as long as a program is shown to be effective, I think there's great promise. And I know, Neil, you might want to add something about the promise for online prevention programs.
So there's the CDC, as you know, began recognizing digital providers of digital DPP back in February, a year ago. and there are about 15, there's actually 30 or 40 on the website, about 15 are actually really what I call digital. And those that use the DPP as its core and as its approach have been very effective, have been able to demonstrate good outcomes. It's obviously different people. So if you look at, some people like to get into a group in person, some like to have one-on-one, some people like to do things anonymously, some want to do it online. My personal bias is that we should give people choice, and that we should, if we're an informed health system or plan or public health department, we're going to allow people to have the capacity to pick what program they want to have at that moment. And some people will gravitate to an online, and some people will gravitate to an in-person. The major benefit of an online is the capacity to go to a large scale very quickly. If it's done properly, you don't have to obviously find rooms and more coaches, and you can do it in a much more rapid fashion. If you can lower the cost and increase the capacity, even if you're not as effective at a public health scale, you're much more likely to have a population health impact.
Yeah. So I'm so glad you were here to answer that question.
That's where I came.
But Sue, can you paraphrase a little bit
Oh,
for folks online?
Sure. So Dr. Neil Kaufman helped respond to this question about online digital programs, saying that the CDC began recognizing them in February a year ago, and a number of them have been shown to be quite effective. And what they really do is offer people a choice for what would work better for them in terms of an in-person kind of prevention program or an online prevention program. And they also offer the advantage that they can be scaled up much more quickly than in-person programs. So I would summarize that by saying they show very good promise. To get back to the original question.
Anybody in the room? Before I go on to the many online questions? Oh.
Hi, my name is Nancy, and I am wondering, in the context of preventing prediabetes and diabetes, we talked about the availability of fruits and vegetables.
Mm-hmm.
And looking at the distribution on the table, I see that, for example, in Imperial County, which is one of the counties that produces a lot of the fruits and vegetables in California, has one of the highest rates of prediabetes. And I'm curious to know if you were able to analyze what the subpopulation is driving that increased percentage or prevalence of prediabetes is, and how that looks for other counties that might also be the strong drivers of agricultural business even for the country.
Okay. So to summarize the question, one of the things we talked about was access to fresh fruits and vegetables and how that may be helpful to improve diets, which can be helpful for preventing diabetes. And you asked specifically about the rates in Imperial County, is that?
Right, or other counties.
Or other counties that produce a lot of the state's produce. And, you know, this is actually something that we've seen in other work where we looked at the food environment or consumption of fruits and vegetables, and we see that the people who live in the areas where the agriculture is a major industry and a lot of the fruits and vegetables are produced don't have good access to those fruits and vegetables. So I think, and we actually do also see high rates of prediabetes in San Joaquin County, which is another agricultural area. So, you know, I think it suggests that there's some disconnect between where the food is produced and how people access the food. Yeah.
So just a quick one, maybe we'll take two from online, because this is quick. Someone asked, is there a quick and fast tool to see if one is at risk of prediabetes? And someone else chimed in online saying, yes, it's called doihaveprediabetes.org. Besides this, do you know of any other quick and fast?
Well, the CDC has a lot of great information about risk factors, and I believe they have a little quiz you can take to figure out how high your risk is. So
just Google the if you want to know about prediabetes.
Yeah, if you Google CDC prediabetes, it'll take you right there. Oh, there's a question in the room. Oh, so the question is there a correlation with economics? And we didn't look specifically at how rates vary by income in this data, but income is one of the predictors that went into our predictive model, and we do know that rates of diabetes vary significantly with income. So I think, economics is definitely a factor, yeah.
Okay, and that there was an online question about that too. Was there crosstabs for low socioeconomic status?
Yeah, and we haven't produced those crosstabs, or we may have produced them, but they're not included in the report. But if folks are really interested, we might be able to add those to the webpage.
Sort of a broad question. What barriers exist to the success of diabetes management programs in California?
Okay, so the question was, what barriers exist to the success of diabetes management programs in California? Was that the question? Okay. So I think, there are a number of barriers. One is people having time to invest in these kinds of programs, because it can be somewhat it requires some time investment, although the availability of effective online programs may help alleviate some of that barrier. I think another important barrier, though, is a lack of coverage for some of these programs, particularly the diabetes prevention programs, are not always covered by your insurer, and as a result, your medical provider may not refer you to a diabetes prevention program, even if they discover that you have prediabetes.
And what about the test itself?
So the blood test that's used to identify either prediabetes or diabetes is also often not covered for younger adults under 45, and so some people may not have access to screening for prediabetes or diabetes.
Anyone in the room before I keep going? We're just going to do a few more, because Sue has been doing interviews all morning long. She's exhausted and she's thirsty, so we're just going to do a few more, and then if you have more, you can always contact us and we will endeavor to answer any questions you have. Sue, what about recommending that doctors refer patients to registered dietitians or health educators at clinics, hospitals? Kind of relates to what you just said.
Yeah.
What about allied health professionals in the fight against diabetes?
Right. So the question is, what about having doctors refer patients to dietitians and other allied health professionals to aid in prevention? And I think that a lot of the the diabetes prevention programs that have been recognized to be effective actually involve pulling together all of these different fields. So diet, physical activity with a goal of weight loss. In terms of, referring people to a bunch of different types of individuals, I think could be problematic, because then if there are too many moving parts, I think things tend to fall through the cracks. But I think these diabetes prevention programs that have been recognized as effective do sort of pull all of these pieces together in one sort of package.
Anyone in the room? Okay, we're going to do two more. What percent of type 2 diabetes patients are in care and have diabetes under control? Do you know?
So the question is, what percent of patients with type 2 diabetes have diabetes under control
And are in care.
That's actually a little tricky to answer, because I think we know from national data that there is some percentage of people who have diabetes and it's not been diagnosed. And so it's hard to know what proportion of everyone who actually has diabetes is in care. If you're not in care, I think you're really unlikely to get diagnosed in the first place. In terms of people who are in care, I don't actually know off the top of my head what proportion of those have their diabetes well managed or under control. But I'm sure there's research on that. I just don't know off the top of my head.
Anyone? All right. And this sort of relates to access to prevention, or lack thereof.
Mm-hmm.
What work have managed care plans done to help identify and provide intervention for patients with prediabetes?
So the question is, what work have managed care plans done to provide access to interventions for prediabetes? I think the short answer is probably not too much. I think the access to, or the coverage of these types of programs is spotty at this point, and that produces a barrier to access to these programs for people who may be at risk for developing type 2 diabetes. But I don't know the details of what specific managed care plans may or may not have done.
Can you do one more? Or?
Sure.
This is the bonus rounds. Okay. Oops. Diabetes or prediabetes prevention is usually difficult to quantify in terms of ROI, return on investment.
Mm-hmm.
Are there any thoughts on calculating emergent risk? Emergent risk quantifies the prevention of diabetes onset along with its comorbidities such as hypertension. I think I'm borrowing from the work done by Dr. Kaufman.
I was just going to ask Neil if he submitted that question.
Maybe. I was alluding to it before, that if you just go back a step, someone has diabetes that's not out of control, and you meticulously manage that as the doctor, the nurse, and everything, you actually cost money. You don't save money. They see the doctor more. They get their blood tests. They get their feet checked. It costs money. So you only save money if you modify other conditions that are associated with obesity, with diabetes, such as sleep apnea, hypertension, high cholesterol, low back pain, arthritis, a whole host of them. So if you look at the long-term ROI, it's clearly there, 5-year, 10-year. But if you're looking at what most plans care about, which is maybe 12 months, maybe if you're lucky, 24 months, you have to look at it in other ways. I don't know if that answers the question.
Okay, so do you want to repeat and then try and paraphrase?
Okay, so can you repeat what the question was for me, because
Okay.
I'm not sure.
Diabetes or diabetes prevention is usually difficult to quantify in terms of ROI. Are there any thoughts on calculating emergent risk? Emergent risk quantifies the prevention of diabetes onset along with its comorbidities such as hypertension.
Okay. So the question is about calculating return on investment for diabetes prevention, and specifically looking at emergent risk populations, which include diabetes and its comorbidities like hypertension. And we're fortunate to have Dr. Neil Kaufman in the room, who knows a bit about this emergent risk idea through his work with prevention programs. And in order to get return on investment, it's actually available if you include these comorbid conditions like hypertension, like sleep apnea, like lower back pain. But it's a longer time horizon, maybe 5 years, than most insurers are looking at, which is usually on the order of 12 months. I think that sort of summarizes.
Okay, Sue, we're going to give you 10 minutes to eat a sandwich before your next interview. I want to thank you very much. Please give her a round of applause.
Thank you.